Introduce to you our guest speakers for this evening. We have with us Lisa Mills and Elena Widman from Sharp Mesa Vista Hospital. Lisa Mills works as a business development and community relations specialist at Sharp Mesa Vista. She completed her medical doctorate degree at Eastern Virginia Medical School and her Master's of Social Work at the University of Southern California. We also have with us Elena Widman. She is a licensed clinical social worker and works as a group therapist and as a clinician for the outpatient assessment team for Sharp Mesa Vista. Elena completed her Master's of Social Work at San Diego State University. Please welcome Lisa and Elena.
Well, thank you all for having Elena and I here tonight. I'm really excited to talk to you about our hospital. Who's familiar with Sharp Mesa Vista? Okay, who's not? There are a couple people. You're not at all. Okay, so most of you are familiar with us. We've gone through a lot of changes in the last year, as I'm sure some of you know. A lot of construction, a lot of trouble getting in the hospital. So we know that there's a little frustration out in the community with us right now. So we just wanted to kind of go over everything that's happened with the hospital, talk about our services, and then field any questions that you guys have for us. Does that sound okay? Okay. All right, let's get the PowerPoint up. No, might need your help on that. Okay. See my click down.
Yeah, you want me to be the arrow for you?
Yes, please.
Okay, go ahead.
Okay, so Sharp Mesa Vista, does everybody know where Sharp Mesa Vista is? It's down off the 8 and the 163. We're right just north of the 8, right where the parking lot with the Stork is. So we're right there on that main medical campus. We share the campus with Sharp Memorial Hospital, Sharp Mary Birch Hospital, Rady Children's Hospital, and then some of the primary care providers, Sharp Reestealing Community. We're the largest freestanding behavioral health facility in Southern California right now. So we currently have 158 beds. We used to have 149 with all of the construction that's been going on in the last year and a half, almost 2 years now. We were going from 149 up to 158, so increasing capacity for the community. We still have 7 inpatient units. 5 of those are locked units and 2 of those are open units. One of the locked units being our ICU. So our hospital, just brief overview, we are freestanding, meaning that we're separated from Memorial Hospital or any other kind of physical medicine hospital. We have a level of acuity all the way from an intensive care unit, level of care, so very, very intense. People that are in extreme crisis would go into that unit. Then they would step down into different units, possibly a locked unit, possibly an unlocked unit. And then ideally, they would transition out into our outpatient programs. Our outpatient programs can be day hospitals, so maybe 6 hours a day, 5 days a week. Some of our programs are organized like that. Some of them go down to 3 days a week, 3 hours a day. Those are what we call intensive outpatient programs, and Elena's going to get a little bit more into this later. We also have the McDonald Center, which is a residential treatment center. It's got 14 beds in that. It's across the highway from the hospital, and that's focused primarily on chemical dependency. So I guess we're going to let Elena go right into adult outpatient, and then I'll talk to you a little bit more about some of our research and things like that. I'm going to let Elena do this because Elena heads up our team that does all of our outpatient assessments. So if you guys have ever had experience with hospitals, you've gone through a triage process, right? So we have a triage process for our inpatient hospital, part of the hospital, but we decided it was really difficult for people out in the community that knew that they wanted to be in some kind of an outpatient program, really difficult for them to kind of get into the hospital and find where they fit. So they'd maybe have to know their clinician, maybe their therapist would have to know, oh, this is a great program for you, or that's a great program for you. But as you'll see, we have so many programs at Mesa Vista, it's really hard to navigate. So we developed a group that Elena heads up, and Elena's been at since the inception of it, that really triages people for outpatient. So people can call in, get a free assessment, really talk through their story, and Elena will help find where they fit. And if they don't fit in our community or in our hospital, then she has so many community resources available to her that she can help people find an alternative if Mesa Vista is not a fit. So with that, I will let Elena take over.
Thanks. So thanks again for having us here. I really appreciate you guys letting us tell you a little bit more about our services. So yes, what Lisa said is correct. I work for our outpatient assessment team. We call it OAT for short. Feel free to You're in the in crowd now, so you can call us Ode if you want to. But basically, our role of our team is to kind of be the one-stop shop. You've reached the right place. You can give us a call and kind of figure out what might be the best fit, if any of our services are the best fit for you. And we know that sometimes, just like Lisa said, sometimes it's not the best fit, and so we'll just make sure you get to the right place. That's our primary interest, is just working at everybody's best interest. So that includes friends, family members, loved ones. We get calls from brothers, sisters, aunts, uncles, adult children, etc., anybody. So anyone can call us.
And just really quickly to interrupt Elena here, these are jar grips, so they help you open up a jar in the morning or get a light bulb out when it's hot. The outpatient assessment team number is right here on the bottom, so we're going to keep giving you that number because it's such a good resource for you.
It's really the only phone number that you need.
Really, it is.
In general. And I'm going to tell you about all of our different programs just so you get a sense of what we have. But most importantly, please don't feel overwhelmed by this information. It's a lot to take in, but you don't need to know. That's the great thing. You don't have to be your own clinician to figure out which of our programs is a good fit for you. That's what our job is. So we do that. So starting with our adult outpatient programs, adult just refers to a general outpatient program that serves the needs of anybody who's struggling with severe mental illness. So it can be a variety of different diagnoses. We have an adult outpatient program at three of our different campuses. So at our main campus, just like Lisa said, off the 163. Also at East County, and that one's in El Cajon, so serving the East County area, and also Mid-City, and that's also very central as well, off of the 15. So we do have a lot of patients. I'll let you guys read all the facts and numbers, probably won't talk about those a whole lot. So that's our adult outpatient program. Then we have specialty programs. And sometimes it's a great fit for somebody, sometimes it's perfect, other times our adult program is a better fit. So that's part of what we help determine. So these are some of our specialty programs, and you guys may have heard some of these terms before, so they're kind of therapy buzzwords that you may have heard, but I'll tell you a little bit about what this means to us at our hospital. So our cognitive program addresses depression, anxiety, so mood disorders and anxiety disorders, and some life issues like loss, assertiveness, trauma, intimacy, conflict. So there's a whole range of issues that they address in the cognitive program, but the way that they do that is through looking at your thoughts and how your thoughts affect your mood and your behaviors. That's basically what COG means to us. It's a very structured program. Our DBT program is also very structured as well. And the way that I like to explain DBT is just that the primary need that people have who most belong in that program is that they have a really hard time regulating their emotions. Really maybe feel out of control, might be doing some self-harm or something like that. And that's usually something that a therapist can spot in someone that they may recommend that they may need our DBT program. So those are the program hours and times. I'm not going to spend a whole lot of time talking about that either, and the reason why is that sometimes those change. So it's always important just to be in touch with us. If you want to know days, times, we can tell you the current information. We do have an eating disorder program that usually starts at a partial hospitalization level. And what that means is that it's about a full day program. That's for people that are struggling with eating and body image issues, and it does offer a pretty holistic treatment team that includes a dietitian as well, individual therapy and family therapy. Dual recovery. Does anybody know what dual diagnosis refers to in here? Yeah, okay. A lot of people are familiar with that term, so that's good. Generally, what that means is that a person struggling with both substance use and mental health. And so our dual program will address how to deal with cravings for substances, triggers, relapse prevention planning, and really helping to get at what might be underlying some of that substance use. So might be something like depression or anxiety. And that program is available at 2 different time periods. This is actually the only program other than our opiate program that happens in the evening. So that's one thing that's usually relevant for people that work. That can be hard for them, but That's an option. And leading into our opiate dependence, the way that I explain this program is that it's very similar to our dual program. However, people that are a better fit for opiate dependence identify opiates as their primary substance of choice. So that could be pills, prescription pills, it could even be heroin, but any type of opiate. That program, you don't have to also be dealing with mental health issues as a part of that criteria, but you might be, and that program can address all of those needs. That happens Monday, Wednesday, Friday. Our chronic pain program, it also falls underneath our dual heading, and the reason for that is that sometimes we see that people are trying to struggle, or people who are struggling with their pain might self-medicate using other substances. Sometimes they do, sometimes they don't. But the main goal of this program is to address both pain and mood, and the idea there being that we know those things are really connected. So if a person has really high pain levels, they might find that their mood is really low as well, or vice versa. So that's that, also 3 days a week. Our trauma program addresses really current and active PTSD type symptoms. So people that are experiencing flashbacks, nightmares, basically trauma defined really broadly. So anything really bad that's happened to you, it's usually an event or a series of events that a person might re-experience. And this program was kind of born out of a need to address military trauma, but it also addresses just trauma in general. We also have an older adult program, and they provide cognitive therapy, but their primary focus is the seniors kind of age group, so 65 and older. And we know that people that are kind of in the age range of either 65 and older, even younger, really benefit from being amongst people in their age group, because you might be going through similar developmental transitions in your life, dealing with common losses or common adjustments in life. And that's what's so great about our older adult program, is just knowing that you can be amongst people who you might really identify with, which really is the whole goal of group therapy. So that's good. Also, our TAE program. So TAE refers to programming for people between the ages of 18 to 25 or thereabouts. It's not a hard number. It's just kind of rough. But people who,
looks like we have a typo on there. Yeah. I think it's actually been bumped up to 26. So I believe it's 18 to 26. Sorry,
18 to 26 or thereabout. What's really important just to know about that TAE age range, and some of your parents out there, I expect, that you kind of know there's this younger age group that hasn't really completely differentiated from their parents, and maybe they're just learning to become adults and they're new to becoming independent and things like that. Maybe someone that still lives at home with their parents, doesn't really have a job or not sure what they want to do with their lives yet, would fit into this age range. So it's really more about developmental state rather than anything else.
This is back to our adult again.
So back to our adult programs. Okay, so that's pretty much the range of programs. I talked you through that pretty fast. And the reason why is this. A, if you have any questions, I'd be happy to field them as soon as we're done. B, as I said, more important to know, you're welcome to contact us if you think that you know someone who's appropriate for any of those programs, or if you yourself are interested, we'll make sure you get to the right place. Just a note about insurance. It's just important to know in general, and this is a part of our regular process with outpatient assessment, is asking questions about your insurance coverage, because we really want to make sure that you're getting a service that's feasible, that makes sense, it's something that you can do, and that you're not going to be stuck with excessive bills for and you just can't possibly afford. So we do ask about insurance. Most private insurance companies do pay for at least some portion of outpatient, and the way that we determine that is we take down all your insurance information and we have our business office do a benefit check. And that just means that they call your insurance to ask about what your coverage is like for all different levels of care. TRICARE as well does typically cover our services. And the one thing we do really want people to know about is that unfortunately Medi-Cal alone doesn't cover intensive outpatient services at our hospital. If Medi-Cal is combined with either private insurance or Medicare, then it works. But unfortunately, they don't cover our services.
Question. If it's not covered for them, can you work on a sliding scale at all if the person's unemployed?
Unfortunately, it's not considered a sliding scale. The way that they do that is that if a person is uninsured or doesn't have insurance that covers our programs, they would be considered at our self-pay rate, which is pretty high for a lot of people, especially if they have a lower income. Mm-hmm. It is $140 per day in our outpatient programs, plus there's a psychiatrist fee. So that's kind of the way it works for self-pay. That is a contracted rate, which is still technically less than what the actual rate would be, which there's not a good answer to what the actual rate is because every insurance has a different contract with our hospital. But yeah, unfortunately, that's the answer to your question is they would be considered self-pay rate, and we don't really have a sliding fee scale. But thank you for asking that question. I know that's helpful for people to know. Mm-hmm. So who to call? Outpatient Assessment Team, or OAT for short. That is our direct line. We check our messages many, many, many times a day. We are not always able to answer the phone when it rings. And usually that's because we're on the phone already helping someone. But we absolutely do return our calls as quickly as possible. Just want you guys to know that in advance. If you do get a voicemail, I know that can be really frustrating because all anybody really wants is just to talk to a live person. And we want to talk to you all too. Unfortunately, I don't have 10 mouths to talk out of. Otherwise, I would be able to get all of our calls. But that's our number. And as I said, please call us if you have any questions, anything that you didn't get to find out from this presentation or anything that's related to someone in particular or where to start. We get a lot of questions from family members that just aren't even sure if our level of care is the appropriate level of care, and that's okay too. You don't have to know that.
The phone call is not dependent upon insurance in any way. That's, we provide that as just a service to the community. So anyone can call in and talk to us at any point to ask questions and get resources. So that's.
And what about these support groups? Are there fees involved in the support groups?
No, those are all free support groups.
All free.
Yep.
Okay.
Mm-hmm. Yep. So we can kind of hop over to child and adolescent, and I was going to talk about that a little bit more at the end. So if you have more pointed questions about that, I'm happy to answer them.
I have a question still.
Say that again? Yeah. Can you explain that? Medi-Cal, Kaiser, where's the cheapest?
If I can just interrupt you guys for a quick note about Kaiser and the way that our outpatient programs work with Kaiser. This may be some new information to people, and strangely, we get Kaiser directing a lot of their members directly to us, which is kind of a misinformation because we do have contracts with Kaiser and we do serve Kaiser members, but the way that we do that is through the Kaiser therapist or psychiatrist who would then say, I really think that this person needs Mesa Vista's IOP, and then they would refer that through our doctor at Mesa Vista. So we do sometimes get calls directly from Kaiser members just wishing to self-refer, and unfortunately at this time that's not the way their process works. They have to go through either psychiatrist or therapist there. Yeah.
Are you still accepting self-referrals for non-Kaiser people?
Absolutely. So yeah, I mean, that is part of the whole point of OAT is so that people understand that there's a place that you can call that does not require a formal referral, doesn't require a piece of paper. The one thing that we sometimes do ask people for when they call is if we can be in touch with your therapist or psychiatrist to request some clinical information and background about your situation, which just helps us know where to start in treatment. But it's not a requirement. Anybody can call us.
Did I see that you're taking TRICARE for veterans? Is that currently
Yep.
you're taking TRICARE to the VA?
TRICARE.
We have a partnership with the VA where we're taking some of the VA patients that are not able to get into the VA clinics hospitals. Yeah. And we've always been very military friendly though. We've always treated family members, dependents. We even actually serve some active duty members for some of our programs like eating disorders. Balboa doesn't have they don't have any kind of resource for eating disorders as far as like an intensive outpatient program or partial hospitalization. So we actually take active duty members and their duty station becomes our hospital and becomes that program while they're going through treatment.
So do you want me to talk a little bit about child and adolescent programs?
Sure, yeah.
So in general, both inpatient and outpatient services for child and adolescents as well. Unfortunately, they don't have an OAT team, but they do have staff that handles all of their intake referral calls, and they actually do have one main line that they expect for people to call as well. And child for us is defined as anything under 18. There's kind of this fuzzy little area that we know about, which is an 18-year-old who might still be in high school. So kind of keeping in mind that that might be a little fuzzy situation where we might look at putting someone like that into our adolescent programs, partially because of their school schedule and their commitments, but also partially just because of where they are in life and, you know, really identifying more with their peers that are in high school rather than 18-year-olds that might be in college. So.
And on the other side, we've taken some very mature 17-year-olds and brought them into adult programs too.
Mm-hmm. Yep. So that's our child and adolescent programs. They have PHP services, which would be partial hospitalization or basically like a full day type program. And they also have a dual diagnosis program as well and a cognitive program as well.
And they work with all the children's programs, the partial, like the day programs, work with San Diego Unified for school, so the kids have continuity with school.
I have another question.
This is just a little bit more detail about the partial hospitalization, but it's, again, working with the San Diego Unified City schools, and the kids get school and therapy. And then the intensive outpatients are also very similar kind of structure to the adult programs, primarily group-based therapy, but some individual and family. Obviously, with the kids, a lot of family therapy. And then I'm just going to continue to sit if that's okay with everybody. What a lot of people don't know about Mesa Vista is we also have a clinical research center. That clinical research center has drug trials that are available to the community. Insurance does not make one bit of difference for those at all. So some people don't want to participate in drug trials. For some people, it offers a whole nother layer of hope. It can be in addition to other therapies you're doing. Some of the trials are an add-on medication to a medication you may already be on. So right now, this isn't very easy to read here, but we have trials for Alzheimer's, PTSD. We have a new depression study, schizophrenia. I think our bipolar one actually just ended, so that needs to come off there. There may be another one coming up though soon. I think that's why they put it back up. But I don't believe that that's an active trial right now. We don't have any child and adolescent also right now. These are all adult studies. But again, this is a group that you can give a call to, and they have certain parameters, obviously, that they need people to meet to be in a study, but it's a free call, a free assessment to see if you qualify for something like that. And it's something that we found that really people don't know about. There aren't that many clinical trials going on that people know about in behavioral health. You hear about all the other ones, but you don't hear about these.
So what would they do in the trial?
What they do in the trial is they assess you, and if you qualify for the trial, then they would give you a trial medication. So in clinical research, the way that our drugs are developed, they have clinical trials. They have all sorts of trials before to assess for safety, and then when it gets to the clinical trials for people, then they put people into two groups. There's a control group, and then there's a group that actually gets the medication. So they're looking at the difference between those two groups, the people that don't get the medication, the people that do. And they're looking to see if it works, basically. So you'd be part of advancing those kind of therapies, those drug therapies, that may be something that would work for you in the future. And so you kind of get the benefit of being a part of that and seeing what's on the forefront. But it is an investigative drug, so there are always pros and cons to that. Mm-hmm. They're obviously they're safe enough for human at this point, but we don't know how effective they are necessarily. Yes?
Would you call the same number to get
for that one?
Now?
You know what? No, I need to get you the number for that, and I thought we had it on there. And I apologize for not having that on there. I can get that to Michelle very easily, and I can also get her a flyer that can come out to everybody about it.
We'll make sure that people get to the right place, though. If you guys do end up calling 8309 and you have questions about research, it helps if you end up leaving a message to say I'm calling for information about research, because that way I can get you to where you need to be quicker. Yeah, this number on here is really the most resource-rich number you can have. Elena will get you where you need to go. No matter if you're calling for something that she doesn't cover, she will get you there. I promise that. Yes. Did you have a question back there?
Do you get paid?
Some of them, I think, have small stipends. Yes. I think some of them do have small. They're not large stipends, but they are smaller stipends, so some of them do. But all of the medication and all of the treatment and everything else is free, too. Mm-hmm.
Another question?
I'm sorry.
Are you the kind where it's like the comparing to a control group.
Yes,
So some of them you don't know if you're going to be
right.
get medication at all. Are there any that are just medication only?
Not right now. That's unfortunately not the way clinical research happens. But if in a trial, if early on in a trial they're seeing that a drug is very, very effective, then they'll stop the trial and go forward with the drug. So, that's promising too.
What drug companies are you partnering with?
Oh gosh, I think they've got Janssen is one of them. Do you know the other ones right now?
I don't know the
I'm
other
not sure
ones.
who the other ones are. I'm not as familiar with the brands. I just know that some of the investigational drugs, like for the depression study, is using ketamine, which is a nasal spray, which some of you guys might have heard about ketamine. And so it's a nasal spray for ketamine.
Has that started yet?
I believe it has started, but I think there's still open enrollment options for that. So a lot of people, you've probably heard of the ketamine clinics across the country that are really helping people that maybe, kind of like ECT. ECT is something that for people that have major depression, a lot of other things haven't worked. For some people, that's the magic thing that works for them. Ketamine is kind of showing that it's maybe starting to be that for other people too. Which I didn't even mention, we do have a very active ECT clinic. We see, I think over 30 patients a day for ECT. So is everyone familiar with that term? Does anybody not know or anyone need explanation on that term?
What is it?
No? It's electroconvulsive therapy. Okay, so it's running a current through to kind of reset, kind of rewire. It's done in a very controlled way. It brings up a lot of bad images for some people because you think of some of the movies, back there that use that. But it's a very controlled, people are very sedated and calm. There's no big convulsing. It's a very, very calm procedure, unlike what people kind of think.
Yeah.
And it can be a lifesaver for people.
Yeah, it's pretty incredible, actually. I've seen it happen and can to attest to the fact that it's not really scary as people might think that it is, and that for some people, not all people, but some people, it's incredibly helpful. Yeah.
What's the difference between the two types of ECT?
Two
There's
types?
right?
Oh, I think you're talking about what's
Full
the
brain
name?
and half brain.
Yeah, that's a good question. I'm not really qualified to answer that, but I'm not sure. Do you know?
On that, I think really it would be up to the clinician that assesses you and your situation to kind of see what would work best for you. I think there are maybe some different risks with both. Like you may have a little bit less memory loss potential with some, because memory loss is the number one complaint for ECT. So you may have a little bit lower risk for that, but it may not be quite as effective. So there's always, just like you all know, with every medication, with everything that you do, there's a risk and there's a benefit. And so, the best thing to do is sit down and talk with somebody through, what those risks and benefits are and make the right choice for you. Because everyone's going to be different with that.
Yeah. Lisa's making a really good point. The one interesting thing and the number one thing that I've learned about the research studies is that they're all just so different. I myself would not try to assess anybody over the phone for that because all the criteria that people have to either meet or not meet or do or not do for a research study, they're all so very specific, and it's just because their goal as scientists is to find out whether this is effective, provide good treatment, and find out whether something's effective. So all the parameters of their studies are a little bit different. But if anybody has any openness to that, it's worth giving them a call to find out what they have.
Yeah, we can absolutely connect you to all the folks over there. They're a pretty small staff over there, so we know them all. And support groups that you brought up. We gave you guys a sheet. I don't know what I did with mine. This has got all of the, if anyone didn't get one, I think that might not be it. Mike's passing them around if you didn't get one. We host a lot of different support groups at Mesa Vista, and that list, that schedule will tell you what they are. And also, that's for the main campus now, and Michelle also has a group out in East County too.
So if it says closed, you can't go to
A closed group is not open to the public, so it would be something where you get in touch with the organization and go through that way. So it's not just a drop-in.
I thought it was closed or open for students, no?
Oh, is that right? Oh, I'm sorry. She's right. On here it's students. I'm sorry. I'm not.
So what?
So that means, so we have a lot, we're a very academic hospital. We have a lot of students, whether they're marriage and family therapists, social workers, PhDs,
Nursing
MDs, nursing students. We have a lot of academic folks in our hospital. So I'm sorry, Elena's completely right on
so
that.
that question on the far side
On the
about
far
open
right.
or closed is not for consumers or family members. It's a question of whether students can come and just observe.
Yes.
So yeah, that's just more of a question of how protective is the
Privacy.
group of, do they want a person to just come and observe?
Yep, you're absolutely right.
Yeah.
But as with anything, you can always contact these organizations independently too to connect with them. But yeah, you're right. The students would not be allowed to be there on the closed.
And the best place to call if you have questions about days and times or anything like that is actually our front desk, because they're the ones that hold this list. So if there's any changes, they're the ones that have the most up-to-date list of support groups. Did you have a question?
Yeah, I paid cash for my daughter's college program. So she's not a child only, right? That's been like 4 or 5 years ago. She continues to struggle with her illness. Is there a time element where she can come back and get, is there a cutoff to what she paid for, then she can get services in the college area? Or is that just something, if she needs to come back and get supplemental help, is that still available to her, or do I have to pay more for the service?
It would be the support groups or the lecture series that would be open without any cost. As far as I understand, when a person's in the program, they're considered to be in treatment in which they expect for you to pay for that treatment.
Right.
I don't know. What I do know about our cognitive program is that they do sometimes have some aftercare things. In which case, I would say if your daughter has the phone number for the cognitive program and wants to even ask them directly, hey, is there any aftercare I can come to? I don't actually know the days and times, and that's probably a good thing because I don't need to know that. It's really for patients that had just recently finished the program.
Or she would contact the program?
But she would contact the program directly.
And
for
you know,
that.
another group, the COG Family Support Group here might be a good one for you to go to. That's on Thursday night.
I've been
You've been that one, so that would be a good place to bring it up
and
to.
you can certainly ask them that question
Absolutely.
there too.
So this probably relates to that, the family, like CBT, informed skills family support group, so that's for family members of somebody who's in the program? Is that right?
It could be.
Or have-
It doesn't have to be.
Right.
Yeah, it doesn't
Or
have to be in
somebody
the
that's gone
program.
through the program. Yep,
So
It's a really good lecture.
it is.
it explains CBT, or what does it do?
Yeah, I absolutely expect that they probably spend a portion of that time explaining DBT, what they do, but I would expect too that their clinicians probably have special topics.
They teach us still.
Yeah.
They do the same lectures that they would do in the program.
Right,
Teaching family
right.
and-
Oh, that's great. Okay, good. Thank you for sharing that because I actually haven't gone to one of their support groups
Yeah,
Well, and
myself
the
yet.
COG
I go to it all the time. It's great.
And in the
Awesome.
COG one too, they kind of bring up a specific topic, like around the holidays, I think they did coping with anxiety around the holiday, or, so they have different themes in the COG one.
I don't know if you have time, but some of these, obviously, you know what it is, Porter's support group, but some of these acronyms, I have no idea what they are, and I don't.
Yeah, well, I can read through some of these. I'll tell you all the ones that I know for sure. AA is Alcoholics Anonymous. Probably a lot of people know that. I don't know what TLC is. Smart Recovery has to do with wellness.
CUBP, I'm sorry, you skipped one.
I skipped it because I don't know it. I'm sorry.
Okay.
Anything I'm skipping, I'm sorry, I actually don't know.
Recovery, you said you didn't know, or you
The Smart Recovery, go
Smart
ahead.
doesn't stand for.
Go ahead.
It's like a 12-step alternative.
Right, exactly.
So, yeah, Smart Recovery is, like 12-step alternative. NA is Narcotics Anonymous. Let's see what else. Sort of support, DBT, San Diego Phobia, Foundation Anxiety Support. That's pretty clear. ANAD is for eating disorders. PA is Pills Anonymous. Someone that asked about PA. I think probably a lot of you are familiar with NAMI or NAMI. Narcanon is like Al-Anon. Am I right about that? It's like a family support group for people that struggle with narcotics. OCD, Obsessive Compulsive Disorder Support Group. Do you know any of these that I'm missing, Lisa?
No, I'm just going down it with you.
CDRP Aftercare
Oh,
refers to actually one of our units. CDRP is our chemical dependency recovery program inpatient unit. So I think you probably either have to have been on that unit before, recently been on it or something to attend that. I
Question?
CODA is Codependent Anonymous.
Yeah, the COG lecture series,
Mhm.
is that something that's like educational?
Yes.
Yes.
That's the one I was talking about, that they bring up topics, like they maybe bring up coping with anxiety around the holiday, or they may bring up a topic like depression, or they talk
might-
through a topic generally.
They might teach a skill like a
Mhm.
thought record, which is keeping track of your thoughts or something like that.
So is it geared mostly towards the consumer, or is it also for family members too?
It's for both.
Both.
Okay.
Either or is who they expect there.
So how do we find out what one of these groups is? So on the first page it says CUBP, so I'm thinking BP might be bipolar, I don't know. Is there anybody who would know?
Our front desk really should know
Yeah, our front desk.
that. So if you just call the phone number for Sharp Mesa Vista, just the main Sharp Mesa Vista phone number.
Can I just point out that it says Concerned United Birth Parent right below that, so that's probably
That's
CUB.
probably what it is.
Oh, there you go.
Thank you for your common sense. We appreciate that. Yes, sorry I missed that. Okay.
Yeah, we don't facilitate these groups.
Right.
There are no Sharp employees that facilitate any of these groups. These all come in from the outside. So unfortunately, Elena and I may not be as familiar as we should be with these because we aren't actually helping run them or set them up. So that's actually kind of a neat thing because they're all self-run. They're all peer-run, which is great.
Excuse me, and these are all at Mesa Vista?
Yes.
163,
Yeah.
okay.
Yeah, so on here it says location, and that's the specific location within Sharp Mesa Vista. But what's really fantastic is that if you just come into the main front entrance, our front desk is always happy to direct you. And it's kind of the Sharp way. We like to take people where they're going and not just say down that way. We
Yeah,
don't
someone
know.
will walk you there if you get turned around. It's very easy to get turned around in our facility. If you've ever been there, you know that. It's a
circle.
It's a circle and a maze, a circle off another circle, and it's I'll show you a map here. I'll do that. But really quickly too, Michelle had asked us to talk about the renovation. So we have gone through a major renovation in the hospital. Those of you who've been there before probably remember kind of the long hallways. A unit might have a long hallway with a nursing station that's closed off and the rooms closed off, everything very segmented off, very institutionalized kind of feel to it. So these are kind of some of the older pictures that you can see, the long dark halls.
You can barely see.
You can barely, I know. And the nursing station, like here, even in our CAP building, thank you, Mike.
Oh, very good.
Was very closed off. So very little access or very little, very big definition between the staff and patients. So when you contrast that to what we've kind of changed over to, there's the new face of the hospital. On the upper left over here, and with the picture that has the exit sign in it, that's the new nursing station. That's so completely different than what we've had before. It's completely open. This is a picture of our older adult unit that has just gone under renovation and has expanded. So you can see that everything is kind of changed. Bathrooms are bigger and more spacious and more ADA friendly. All of the nursing stations are open so that patients have full access to their nurses and their staff. We have common living rooms instead of just these tiny little group rooms. We've got big common rooms. So just a much more friendly environment. Our older adult unit on the bottom left there also looks out onto the children's playground. So they share space now with the older adults, now share space with our children. So it's a really neat energy that happens over there now. So that's kind of just to give you an idea of what we've been working on. We know, like I said, it's been very frustrating. We know it's hard to get into the hospital, but it will be getting better, I promise you, because we are going to be back up to full capacity in about a week. So, well, it'll probably be about 2 weeks, but realistically, by the end of the month, we'll be in much better shape. Yeah.
Well, there was one I was in where it's like partly done and it was open.
Yeah.
When they start renovating the other part, is that the other side still going to be open?
It'll be back open, right? So yeah, we've had to as we've grown, as we've made these changes. When you renovate one whole unit, you've got to completely shift that to another place, right? So we've gone through a lot of that moving around.
I don't know how they do it. I think it's so incredible. I mean, all the planning and effort that goes into making sure that we still have space and care for people that need our services. It's a delicate little dance that they do with moving, this part's open, this part's closed. Yeah.
Well, and all of our rec therapy that we used to have this gymnasium, and all of that has now had to shift to outside space, which has been really great because we offer things now like Tai Chi and yoga and Qigong and a lot of meditation, group meditation that can happen. Now it's all happening in the outdoor space, in these beautiful gardens that we've created now because we've reclaimed that space to have more patient space.
But like a unit where they've already partially completed
Yes.
renovation, when they continue the renovation on the rest, is it going to shut down the whole unit or?
No, it'll probably just shift around just like it has before.
Yeah.
We have
Depends
158
on their
beds in the
plans.
hospital that we're licensed for right now, but as that kind of thing continues to go, there's a certain number put aside so that they're used for that kind of growth and renovation. And just we can move them around. We get people moved and different spaces get used. We have a lot of office space that can get converted into patient rooms. So when renovation happens in one place, maybe this particular hall, maybe down the outpatient hall, those spaces that are office now are able to be converted back into patient space while the other space is being worked on.
In the
Does that
back,
make
though,
sense?
you were waiting patiently.
Yes.
Yeah, I was wondering, this sounds great, I don't want to take away from that, but have they done anything for the parking?
Oh, yeah, I know. None of us can park there either, so we all scout the streets. No, they have not done anything about the parking, unfortunately. There's just no space on that campus. I would love to see that happen. I'd love to see a parking structure right outside of our hospital, but right now there's no plan for it, unfortunately.
Can you park in that big structure, or is that just short?
You can park in our lot, which our lot is actually starting to free up a little bit.
Lisa, that actually had changed in the last 2 or 3 years because I know that there are people who didn't know that before because staff used to park in that front lot, and that shifted within the last 2 or 3 years. So all of the front parking lot.
Right, the front parking lot.
Right, so when they got the parking arms, staff is no longer technically allowed to park in those front spots. There are physician spots up there, for the psychiatrists or whatever docs. But technically, though, staff is not parking in that front, so we hope that helps.
It's still tight, but most days that I'm there are spots out front. So.
My daughter had to go inpatient last summer, and unfortunately, you guys didn't have any beds available. So I would love to know how to get inpatient at Sharp Mesa Vista if there are no beds available. How does it work? Is there a trick? What can we do?
Oh man, I wish there was a trick, but when we're full, we're full. I mean, there would be no reason for us to turn people away when we're full. So
that makes no sense.
Yeah,
in the world.
and so I
Okay.
completely get your frustration. It's the common thing that we hear in the community is that people just can't get in. And I know that in the county in general, the lack of beds for adolescents is just crazy right now. So, I wish I could tell you that there was some trick to get in the door. But really, if we don't have beds, we don't have them. Hopefully, did they help you get resources somewhere else? Were they helpful with that at all?
At the time, no.
No. Well, you're in crisis too, so
yes,
it's tough.
That wasn't the time for it.
Yeah.
Also, do you have a chronic pain program for kids under the age of 18?
Not for kids yet. Mm-mm. No. Is that something that you think is
I did have some comments about, my younger daughter did the partial hospitalization program in the fall, and one of her issues was chronic pain and clinical depression and everything, and I did have I'm very happy that you're interested in hearing from the community about comments and stuff, and I actually was surprised that there was no interaction between the parents and the psychiatrist whatsoever unless I initiated it, and my daughter was in the program for it was a little more than 2 weeks, 2.5 weeks, and if I hadn't called to speak with a nurse or a psychiatrist, nobody would have talked to me, and I think you guys should know that.
Definitely.
I think that's something that needs to be looked at, and in addition, there's
write this down.
and I mean, I just think as a service to the community, you should know that that's insufficient. And in addition to have one meeting per week with a caseworker, again, I was just surprised. You bring your kid in from 7:30 in the morning until I think it ended at 3 or 4, and there's an expectation that you're going to talk to a caseworker once a week. And that's it. To me, that's not adequate when you're dealing with a kid.
Yeah.
And there was really nobody who I mean, I didn't follow up afterwards, but nobody even asked. There was no evaluation afterwards from the parents about any kind of feedback about the program. And I'm very happy. I was so happy that you guys were coming because, as you know, you get to hear kind of some of the experiences. So there is no chronic pain
No
program.
chronic pain for kids currently.
Okay.
Yeah.
Yeah, absolutely. And just so that you guys know, I mean, my team is kind of the forefront from hearing these kinds of feedback, and we get it a lot and we get it all day long, but it all matters. Everything, any comment that anybody brings to us, I think it's just our primary concern of wanting to make sure that we're doing our best to meet everybody's needs as possible. And so all these things I bring directly to my manager, as a matter of fact.
And is there somebody that you recommend that I speak with? Because I definitely would be happy to talk to someone. If it's the right person, I don't want to waste time talking, I call somebody.
Yeah. Alicia Carpenter
Okay.
is our lead for that. She's the manager of the Child and Adolescent Services, Alicia Carpenter.
Thank you very much.
Yeah, absolutely. In the back?
I would just second that. I think it's super important. My son also was in as an adolescent, and it's super important that you treat that whole family.
Yeah.
Because it's so huge when this happens. And the other thing I would ask is, I'm learning, I'm going to be taking a class on becoming a peer support specialist.
Great.
And I wondered if the adolescent side has anything like that, volunteers that come in. That would have been really helpful to me to have somebody who has already been through it. And you could have volunteers out there that could hook up with the family members when they are in that crisis mode.
You know what we're actually looking into right now? We have you heard of the NAMI Friends in the Lobby program?
Yes, and that's what I'm asking if you're going to have that.
We have it right now in our main lobby, and we've had it for a long time in our main lobby.
But that's the adult side.
But that's the adult side, and we're actually talking with them. I actually just had an email exchange with them this week about having them, once everything kind of comes to an equilibrium over in that building, because that building's the one where the new unit's coming in. So probably by the end of the month, having them have a presence over in that lobby.
Yeah, okay, that's great.
So we're going to bring them over there too. Yeah.
Yeah, over there.
Yeah, when I was an inpatient, there was a peer support person who was there. I think they were volunteer, and they sort of like supplemented the staff. They were able to talk and things like that, maybe talk about resources. I'm not sure about outpatient.
Yeah, that's helpful. I think one thing that everybody's kind of thinking of and has on their minds how much and how important it is for family and friends to be involved in treatment. And within our adult outpatient programs, it's hard for me to speak for child and adolescent because I've actually never worked for any of their programs at all. But within our adult programs, I know that they're actually working much harder than ever before to involve family and friends. Like, for example, our dual diagnosis has a family support group specifically for family members of the patients that are in the dual program at that time. Especially our TAY, our Transitional Age Youth Program, is super special when it comes to involving parents in treatment. Because at that point, you're talking about an 18, 19-year-old who might, in the words of some parents that I've talked to, function at the age of a 12-year-old, like 18 going on 12 or something like that. So our TAY program works really hard to involve family members as well. So all of your comments are really going towards actual change.
Right. And there was a peer program in the hospital a while ago, a long time ago. We don't have that program anymore, but a lot of the people that have gone through our programs volunteer back at the hospital. So we have a lot of people that are volunteers that are peers. There's just not a formalized program right now for that.
Right here.
So a couple of things. So the kind of full bed, all the beds are full. When my daughter was in there, adult daughter was in inpatient somewhere else, she got out and then did the intensive outpatient COG program, and she was in it for like 2 months. And we were told conflicting things that, a bed could be made for someone who was in the intensive outpatient program, and like sometimes people would come in and say, okay, someone needs to go inpatient today because they're having a hard time, and clearly, the person who's facilitating the group, sees the need for that, and they sometimes people can wait a day or two for a bed in a better place. And so we were told that you guys had the ability to move somebody from potentially a locked unit to an unlocked unit, or unlocked unit to a locked unit, to make a space available for someone who's already a patient there for continuity of care. Because you've been seeing like this doctor for 2 months, and now you need to go inpatient, and if you go inpatient somewhere else at county or
it's harder. The continuity of care is disturbed.
Wound up that my daughter went into Scripps Mercy and didn't receive any care there. And then had to go back, to Sharp Mesa Vista outpatient.
Right.
So, I mean, the question is there any way for continuity of care where a patient can
That's always the goal. I mean, the goal is always continuity of care. But if we've got, people that are already taking those beds, we can't inappropriately move somebody from an ICU to an unlocked unit or something.
I think what they might have been referring to, and maybe I can speak to this, because I somehow get in the intermix of all different levels of care, because I talk to people on the phone who think they want outpatient or do want outpatient, but from my perspective as a clinician, that may not be safe and may not be enough for them. I see our intake department as a chessboard of many moving pieces, of which many people really can't understand. Even clinicians that work in the hospital can't understand how complex and how all those pieces work together. So I think what the program may have been talking about is the fact that people do move and transition throughout the day. Our intake staff, and certain intake staff, not all of them, kind of know like what might come open, what's happening. But what they also know is that there may be 10 people that have been sitting in the ER waiting for a bed for 2 days, taking up an ER bed or something, when what they really need is to be admitted psychiatrically. And they may also have, me who said, I just talked to someone on the phone and they really need to come in. What do you got? There is no preferential treatment, I think is what's really important for people to know, and that it's just a matter of acuity.
Exactly.
It's a matter of what's available. So they're going to shuffle and do the best they can to accommodate it any given time. But it's always going to be the patient's interest. Female beds, male beds, and our programs also have to navigate and tolerate that same issue of like,
So
if the public hears we have no beds, so do I, so do our programs.
So you mentioned something interesting there. So if you came into the Sharp ER at Mesa Vista.
Actually, there was no ER at Memorial.
Next door, right?
Exactly.
Yeah.
And it was clearly a psych thing. You were bipolar, having a manic episode, and really needed help. And there were no beds available. Would they let you sit in the ER for 2 days?
It depends on if a person.
What else is available?
It depends on if a person is holdable.
Right.
And it depends on a lot of factors that, kind of when a person's in the ER, they might be like, yeah, I want to harm myself now. Okay, an hour from then, nah, I think I'm safe. I'm ready to go. Right. So there's all of that interplay. But then there's also the fact that they're trying to get that person where they need to be as soon as possible.
They're not just trying with Sharp Mesa Vista.
Right.
They're trying
anywhere
that they
exactly.
can.
They're trying they need a bed. So from a clinician standpoint, we need to get someone to the appropriate level of care. And I think continuity of care is a consideration. Just like Lisa said, yes, that's always our goal, is if you're a patient of Sharp Mesa Vista, if you've been in our programs, it's not about preferential, rather it's about continuity, just like you said, knowing that the doctor knows the patient, that you have an advantage in treating somebody if you know what their needs are already. But yeah, does that make sense from the ER standpoint?
So people sitting in the ER is not just because they're waiting to come to Mesa Vista. It's because the county is in an extreme shortage of beds, period.
Right.
And so it's really hard to get people placed anywhere for inpatient services.
Yeah, they're sitting waiting for a bed, any bed.
Anywhere.
Understood. So I wanted to additionally make a comment. I read through, when my daughter was in the COG program, the book, the material, and would discuss the sessions afterwards with her. And one of the things I noticed, and it's been a consistent comment in the friends and family support groups here, is that it is really geared towards depression. Like a lot of the COG materials, if you go through that COG book, mania or hypomania is mentioned 2 or 3 times in the entire book. And so it's very much about treating bipolar depression. And I think for someone who is suffering from a mixed episode especially, where they can relate partially to the depressive part of the illness, very little is discussed about the kind of mixed episode or the part of the bipolar illness if someone is not suffering a euphoric mania, but is suffering a mixed mania, or a mixed hypomania. And so I felt that there was extraordinarily little information on that element of bipolar, and a lot of information about depression.
In the literature itself, primarily?
In the literature and also in the lectures.
In the lectures, too. Okay.
Yet people in the group were talking about manic episodes and, in group, but it didn't seem as though even the professionals there, the therapists that were facilitating the groups, were really dealing with the lack of reality in bipolar and anosognosia especially, and patients, denying, or it's different than denying, but unable to process their illness, which is much more significant on the manic side than on the depressed side. And I felt that was prominent from someone who experienced it, every working day for 2 months. So,
Okay, so good curriculum information for sure.
So that was the main thing.
Okay, so we'll bring that feedback back to our COG department, definitely. We had one question back here. That was
If you could plug your plane tree stuff.
the plane tree. Okay, so plane tree is a designation that is given to hospitals that rewards hospitals or recognizes hospitals for being patient-focused. Part of being patient-focused is the environment. It's your clinical care, but it's also your environment. So when we were looking at these pictures, that was part of what we were trying to do with this environment, is change from kind of an institutional feel to a feel that feels more like your living room. So we're starting to incorporate things like therapeutic gardens, different treatment modalities like the Tai Chi and the yoga and all of that. We're even looking into some aromatherapy and alternative kind of therapies like that, art therapy, all of these things that really make it more of a patient-empowered, patient-focused environment.
And I understood from something that our director said was that they're going to be developing some programs that have to do with more family and friend involvement too. So to the point of what everybody was talking about before, that's another initiative that's involved with Plane Tree that will be coming down the line as well.
Patient and family focused.
Yeah.
I'd like to emphasize the importance of that. My daughter was in the hospital at Mesa Vista recently for 2 months, which is a really long time. We had maybe 2 family conferences, and they were initiated by me. Is it typical that the psychiatrist or it was hard also to figure out who her social worker case manager really was? Is that typical, or do they have routine, family conferences? Because I was surprised, especially for as long as she was in, that didn't occur.
I would really like to say that should be the standard of care, and I'm hoping that that's standard of care, but from what I'm hearing today, that's not what you guys have experienced. I know, like Elena's saying, that the hospital is much more focused on family right now, and this started about 8 months ago maybe, where they really started focusing in and bringing more family groups. Family therapy is something that should be done. It should be done routinely, I believe. I think that it has been historically, because so many other things are group focused on the patient. they're not scheduled.
Excuse me, I was not talking about family therapy. I was talking about case conference, about
Okay.
what's going on, because when I would
Okay.
hear from my daughter,
I think a lot of that comes with family therapy. I think that's why I was going on this, but I see what you're saying. So more
Yeah.
of kind of a consistent
yeah, just
checking in
to-
with the family,
right, because
updating
when
with
we
the
did
family.
have it, it was extraordinarily helpful, because then I could hear from the psychiatrist, the social
Right.
worker, and sometimes even one of the nurses there, and then we could give our feedback too, so everybody kind of
On
understood
the
where
same
everyone
page.
was.
Yeah, you're on the same page, right?
Because, I'm sure that other people can attest to this. Our daughter was, struggling. And so whatever I heard from her, I couldn't tell what was really
What was happening.
So.
Well, part of what you did is something that I think is really important to encourage people in your situation to do, which is just to advocate. And that from our perspective, so in our outpatient assessment team, we also assess patients while they're hospitalized for participation in our programs. So part of what I'm here to talk about with you today is really more about the community side and taking those calls from the community. But we also do assess people on our inpatient units. And so we also have kind of a bird's eye view of the inpatient experience as well. I know that people say that they wish that there was more family involvement there, and sometimes that doesn't always happen. I can't speak for, how and why and all the factors involved with that. But one thing I can say is I've heard a lot of feedback from other hospitals that other hospitals don't have it at all.
Yeah.
Where I'm definitely seeing at Mesa Vista, there's some attempt to be in touch with some family member at least, if not, then to encourage and to respond to your requests. So if anything that I can say for that side of it is, please don't be afraid to ask for those things. Please be assertive about getting your needs met when it comes to how you want your family to be involved with your family members' care at our hospital, because I can tell you that that's something that anyone on our team wants to hear from is what your needs are. Sometimes they just need to hear it, but I'm sorry that I don't have a better answer.
But we do
as to-
recognize when you're in crisis, and you don't feel like it should be your job. They should be keeping in touch with you.
Well, it's also hard to know who to
approach.
contact, and I don't know, this is just coming out of, because I am a nurse, I'm a retired nurse, but we used to have, if you had, in certain situations in the hospital, and this isn't always the case, but a nurse would be assigned, was the case manager of that particular patient. She was he was the go-to person that could fill you in, so you don't have to have a meeting with everybody, but could kind of fill in and connect the dots and fill in the information.
I think in inpatient, social workers are doing that a lot for us.
They are, but I found that not
we do. It depends on the unit, and it depends on whether it's weekday or weekend.
And they
it
would
also
have
depends
different-
on if
they would
someone's
have
on
substitutes,
vacation.
which I understand you have to.
Well, I called
Yeah.
the nurses when my son was in there, and I would talk, and they would be different, they would change, but I just bugged them.
Well, I did that. I called the
Yeah.
nurses, but it was disjointed. It wasn't very, there wasn't much continuity.
Well, especially when you're wanting to hear feedback from all of the different
Yeah.
facets of your child's
Anyway, I don't mean to
treatment.
complain, because
No,
I
no,
agree.
no.
No, it's
This is
okay.
this is
Your
why
feed-
we're here.
Yeah,
We wanna
your
hear
feedback
that.
is welcome,
Very, very good.
absolutely.
That coming together would be helpful.
That would be good. So kind of a more consistent
Right.
check-in with the family.
Yeah, and the go-to people.
Okay, who's if I have a question, who's my person? Okay.
Over there?
It's okay, I'll bring it next week.
So I want to thank Lisa and Ella. I would like to invite you to come back. And I'm most of us in here are friends and family.
Great.
And I really think that some of the mental health consumers would have benefited. And if we had more mental health consumers in this room, I think we would have had a different kind of
Different conversation. Sure.
So,
Hi, Cass. That's what it's called. Health Insurance Counseling and Advocacy Program. If you call them, they'll find you a good insurance program.
Awesome.
That's great.
so we would like to invite you to come back and maybe have a session with the mental health consumers.
That would make sense, yeah.
Sure. Yeah, thank you for having us.
You've got our PowerPoint.
Yeah.
Thank you.
Thanks for all your feedback, everybody. We will take it back to the team. See what we can do. Thanks for the tech support.